prosthesis being given, wonderful prosthesis by so many speakers. I would just like to your opinion on whether we should go in with a fixed hybrid prosthesis or a metal ceramic with pink ceramic as it was told today. And what would you recommend in cases? Uh, how is the maintenance for fixed hybrid? Means once it is fixed in a longer, in your experience, because I am very new to this strategic implantology. The, and there was a presentation which said we can even go about doing a fixed hybrid, total fixed hybrid using zirconia. So I would like to know whether that is recommended for such long bridges, long span prosthesis.
What do you mean long span? I mean, it's always from 6 to 6.
That is cross arch, complete arch.
Uh-huh.
Because in our conventional FPDs, zirconia is not recommended for more than 5 units if we are placing a fixed bridge. Then we are using zirconia for a complete arch here, for a fixed hybrid or a fixed complete prosthesis of.
Well, I think the rule not to put zirconia more than 5 units it's true for teeth, you know, because the teeth are intrudable. They are like you know, on the water, and the implants are ossifixated or osseointegrated, and there is not so much vertical mobility there. So I didn't do too many bridges with zirconium. I remember that we did a lot of them many years ago when I worked for a clinic in Prague. You see, usually these bridges have a lot of volume, so they don't tend to break into 2 pieces. The difficulty with zirconium is rather to overcome disparallelities of the implant heads, so to get this bridge in, because while it gets in, if there are disparallelities, there are tangents, and then part of the zirconium, I mean, these abutments, these technical abutments, for example, distal technical abutments, they can break out. So I'm not so sure if zirconium is really a good material for this. I mean, we nowadays treat the patients as a rule with metal composite bridges, so they are very beautiful. We have the possibility to reconstruct also the soft tissues, and I would rather today, I mean, really cut away a lot of bone in order to bring this transition zone, this visible zone between the patient's gum and my gum, which I give him, into the non-visible zone. So I'm not worried to cut away also a centimeter of the maxilla, because anyway the second cortical is there. That's the only thing that we need, and if I create only enough atrophy, there won't be too much bone available to shrink away. There won't be too much more atrophy possible, and also if this transition zone is quite high up and covered by the lip, also from the phonetics point of view, this gap will be small, and the patient won't complain about, you know, this air and liquid coming out. The other point that I want to mention, Dr. Lazarov, if you remember, he said that he creates a self-cleaning possibility. From my experience, the most important is that the patient's tongue has the possibility to access from the lingual or from the palatal side to the bridge, to this transition zone between the where this implant goes in. If the patient can keep this clean, there will be never any infection, and then you have the possibility to even make a shield, a vestibular shield, a pink shield, which then supports very often massively the upper lip and increases the aesthetics. From my point of view, this is not so easy to do in ceramics. It is possible. You need well-trained dentist technician to do that. To do this with the metal to composite bridge is very easy. It's really very easy. Also, our lab is directly next to the clinic, so then we try this in. We check the morphology of the upper lip and lower lip, and then we can just add. I mean, this composite is easy to add. If something